Thanks so much, everyone, for joining us for the Center for Translational Research's Enrichment Lecture Series. I'm Stephen Hardy. I'm a pediatric psychologist in the divisions of hematology, oncology, and BMT. I'm also co-chair of the CTR's Behavioral Research Special Interest Group. Our SIG is pleased to be co-hosting today's CTR Enrichment Lecture Series. And it's my honor to welcome our speaker, Dr. Lisa Saldana, who's a senior scientist at Oregon Social Learning Center with a research emphasis in evidence-based practice and public serving systems. Her clinical and research emphasis involves addressing the needs of families involved in the child welfare system. A clinical psychologist by training, she's an implementation scientist focused on the development, evaluation, and implementation of prevention-focused evidence-based practices. Dr. Saldana is the developer of the FAIR, Families Actively Improving Relationships model, an integrative treatment for parental opioid and or methamphetamine abuse and child neglect. FAIR was recently recognized by the California Evidence-Based Clearinghouse. She's also the developer of the R3 Supervisor Implementation Strategy for the child welfare workforce, an evidence-based approach to improve the culture and climate of child welfare systems, with a focus on infusing the use of evidence-based strategies in all interactions with families. Finally, Dr. Saldana is the primary development of the stages of implementation completion, or SIC, and cost of implementation new strategies, claims, measures of implementation process, milestones, and resource use. The SIC and COINS tools have been used to track over 2,000 implementations of different behavioral and physical healthcare programs worldwide. Dr. Saldana has been the PI or co-I on multiple federally funded grants and has served as a mentor to many junior investigators with an interest in implementation science and evidence-based practice in public service systems. So I'm now pleased to be able to invite Dr. Saldana to take over and share with us her presentation titled Implementation in Child Welfare Settings, Bringing Evidence to Systems.
Great, wonderful. Thank you, Stephen. Thanks everybody for coming. I know that this is over y'all's lunch hour, and so I appreciate people spending their lunchtime with us today. I'm going to go ahead and share my screen, and then here we go. All right, so thanks again for the invitation to be here. It's really nice to be able to speak to folks and have a group that I hope is the size that perhaps at the end we'll be able to have some good discussion. I welcome your input and your ideas as I share with you sort of this portfolio of research that I've been conducting for the last several years. So this morning, I'm going to be sharing some information with you around the development and just sort of what the models look like for FAIR, so Families Actively Improving Relationships, and R3, the model specifically for the child welfare workforce. I'm going to start off though with FAIR. And so to begin with, FAIR is a model that was well, as the first model that I developed, this was really developed out of a K award that I received shortly after, entering into the field from graduate school. And so to begin with, here's my team. It is always growing and changing, which is lovely. But so when I got my K award, I knew that I was very interested in working with child welfare systems. I knew that in so doing that I needed to understand more around the relationship between substance abuse and families who are in the child welfare setting. So I received my K award, was very honored to be able to do that. Actually received that when I was on my way moving from one institution to the other, moving out west. And so the timing was really perfect. What I did to begin with at the very beginning, though, was I traveled around the country and talked to a bunch of different child welfare stakeholders, judges, attorneys, supervisors, some families themselves, and really found that no matter where I was in the country, what they were speaking about is this intractable issue that I think we all know about. I know you guys are working in pediatrics. I'm sure you see this. And for those of you who don't, you hear of this and are very well aware of the transgenerational and sort of intractable cycles of child maltreatment and parental substance use. And so no matter where I went, folks were talking about that being the greatest challenge, regardless of what the drug was. So the drugs were very geographically oriented. Some, areas were more focused on cocaine at the time, others more on, heroin. But regardless, there was this intractable cycle. What everybody sort of talked about is that if they could, everybody agrees on for child welfare, sort of what the menu of recommended or mandated service are. So they include treatment, they include developing some social stability, pro-social peers, good networks, but then also needing to sort of navigate through the legal system. A lot of families involved in the child welfare system are not just involved in child welfare, but also the court systems and criminal justice systems. And everybody sort of agreed that when families were able to receive this constellation of services, that we were more likely to then see both the proximal outcomes for families and the distal outcomes for the system. The problem, however, is how do we move folks from these cycles where we have these poor social determinants of health that are really driving both child maltreatment as well as parental substance abuse, when those things are so interrelated, and where families would start to make, move the needle a little bit on one aspect, but then these bidirectional relationships between the two would really continue to drive this cycle. So FAIR was developed to become right in the middle there, to be able to be an intervention that could bridge this gap and help families, those families that are experiencing those poor social determinants of health, and really kind of propel them to this other side of the model where they're able to receive these services. And so with that, what I developed then was an integrated sort of one-stop shop model where we go out to families in the community. My roots are with multisystemic therapy. I sort of grew up in the MST world in graduate school. And so really drawing a lot from Scott Hingler's work and others' work, and then merging that with the work that I was able to begin working on as I moved here to Oregon Social Learning Center. So the FAIR program, as I mentioned, is an integrated program where really the mechanism of action that we're really focused on is engagement, wanting to keep parents and families engaged in meeting these 4 different quadrants of treatment needs. And so with substance use, how we treat it is we use evidence-based practice, contingency management. We also draw and bring in a lot of FAIR-specific tools and assessment measures around understanding fit, sequences of events, sort of day planning, how people are spending their time, how we can find modifications for them, and then really it's a very action-oriented model. So really going to those places with individuals and creating change in cue recognition, for instance, within their physical environments. For parenting, we also are doing in vivo coaching. We use Parent Management Training Oregon, PMTO. Some of you all might be familiar with it. I had the good fortune of moving over to Oregon Social Learning Center, where a lot of these parenting models are developed. We modified them for FAIR to really focus on neglect. So also not just looking at things like non-harsh discipline, but now introducing things like nurturing and attachment, safety planning, nutrition. So more of those sort of skills that are needed. For mental health, we found, so I will say, I'm going to take you through the development of this program, but at the beginning, it was really just parenting and substance use in the first feasibility trial. But then as we were working, or I was working with my team in the pilot trial, we started to recognize that it was pretty impossible to ignore the co-occurring needs for mental health and ancillary needs. So for mental health needs, what we do is we use cognitive behavioral strategies. We still really rely on our behavioral approach to be able to engage people in their mental health and the CBT strategies that we use. Over 90% of individuals referred to FAIR come to us with the diagnosis of PTSD. Many of them know that, but a lot of them do not. And so when we're first meeting them, we're helping them to sort of understand the experiences that they're having, where others have maybe diagnosed them with more severe psychiatric types of disorders. And then we have our ancillary needs. So our ancillary needs really are where we focus on those social determinants of health. A lot of the things that parents need, families need to be able to successfully navigate the system, that child welfare, the court systems, et cetera, they don't have the basic documentation that is necessary to be able to do that successfully. But then also a lot of folks have not been to the doctor in years. A lot of folks have been using substances for a very long time. And so really helping to get back on top of physical healthcare needs, dental needs, et cetera, things like that. So as I mentioned, our mechanism of action that we really focus on is engagement. And so how is it that we engage with folks in a way that's different from traditional treatment? So like a lot of the other family-based EBPs, we go into the community and offer flexible scheduling. We also have non-traditional treatment sessions. So a lot of our sessions are not sitting across from somebody, but again, they're action-oriented. We're doing things. We might be going to the grocery store. Folks have not maybe done that sober for a very long time. It's really overstimulating to have flashing lights, have people talking to you over an intercom, have people coming at you from different directions with their shopping carts. How can you manage that in a calm way? And so those are some of the things that we do, really out there skill building, while we are also integrating those CBT strategies for mental health, also integrating those contingency management strategies for substance use. So offering these non-traditional treatment sessions make it more comfortable for a lot of the families that we work with. We also use fare bucks, which is basically monopoly money, as part of our contingency management system. And folks are able to spend that money at the fare store. So here's an example, an image rather, that one of my senior clinicians drew up to really sort of show what it is to be a fair clinician, a fair therapist. And so here's an example of maybe a clinician who might be going to a doctor's office with a client, might be going to a probation officer with a client, might be needing to fill out, I don't know, I thought that they were filling out school registrations, but apparently this is talking to an attorney, the artist told me. Or meeting folks in a park, we meet people where they are at. And so a lot of our folks at any point in time, we have a large majority, about 60% of the population we serve are unhoused when we first meet them. So we might be meeting them at a park or at a tent at a campsite. We'll meet folks in the coffee shops to do resume building, help them look for jobs online, do house hunting. But then a lot of our sessions happen in the car. I have clinicians who will first be joining us, who are new to our team, who will say, oh gosh, I don't think this client's going to work out. He just won't talk to me, or she just won't tell me what's going on with her. And we have a phrase in FAIR, which is, less talk, more action. We don't need to be talking in order to really help people become behaviorally activated to create changes in their life. And in so doing, create really big changes for their families. So as I mentioned, we have fare bucks, which are the sort of monopoly money. And so you could earn fare bucks. We are very liberal with them. So you can earn them for taking a negative UA. At the beginning of treatment, we might give you fare bucks simply for agreeing to take a UA, regardless of what the outcome of that UA is, for maybe trying time out with your child for the first time, or remembering to bring a nutritious snack to their visit if you are working on a visitation schedule with your child because they're in foster care. So anything, showing up for treatment, getting out of bed in the morning if you have depression, all of these sorts of things we're reinforcing with fare bucks. And folks then have their fare bucks to spend at the fare store that is stocked with donated goods. One of the things that I think really brings the magic to FAIR is this idea of the resource building. And so we have a part-time resource builder as part of our team, and that person's job is to go out and to build partnerships both with community organizations, with more corporate organizations, and to really help us to be able to have things in the store where that are going to be helpful for creating safe, sober, stable households. The FAIR store is a really, really nice in vivo opportunity for us, even for our parents, of course, who are unhoused, to be able to have a sort of a very easy and low risk opportunity to learn about things like prioritizing what your household needs are, understanding what hygiene needs are, what maybe school supplies are necessary for your child, purchasing things like making the choice of laundry detergent over some really cool little, like, fidget spinner or something like that. And so we have things that are for adults, but also for families and also for children individually. We also are able to have things like activities. So our resource builder will get us passes to this, like local public swim club, perhaps, or for bounce, where they're the trampoline parks, things like that. So things that parents can earn. And then this gives us the opportunity to work on things like budgeting with them in the house, in the fair store. Again, these sort of activities that normally we would be able to do if our families were more resourced, but this allows us to do that without them being limited. And I'm having a hard time. There we go. And then another key part of FAIR and the FAIR program is that we do a very deliberate and intentional job of partnering with, in our case, ODHS, so Oregon Department of Human Services, but with child welfare and with the criminal justice system. And so one of the things that's really key about this is I hear a lot of folks talk about, oh, we don't talk to the public serving systems because, because of HIPAA and things like that. All of that is true. However, what we want to do is we really set ground rules at the beginning, and we work with the parents. They know that part of their involvement with FAIR is that we are going to be working as part of their treatment and care team that includes these other outside service providers, because that's what's necessary for them to be able to achieve reunification or maintain family stability, family permanency in their homes. And so we do this in partnership with them, but we also really strive to work with these individuals, so with child welfare, with probation, to recognize our own individual roles and responsibilities, and that oftentimes we're coming at cases from different perspectives and different angles, but together with each of our perspectives, we're able to move parents and families along sort of their treatment continuum so that ideally they are able to exit the system and maintain after they have exited the system. So this is what FAIR looks like. I'll just show you very quickly. So as I mentioned, we did a feasibility trial, and that was followed by a randomized pilot as part of my K award way back when. And at that point, we were limited to mothers. But what we found is that we had really strong engagement outcomes, particularly compared to those that were randomized to treatment as usual. And so what we found is that folks were engaging in treatment. They were also completing treatment at much higher rates than what we found in TAU and what we find in the literature. We also were seeing that we were moving the needle on the parenting outcomes like we had hoped, on the substance use outcomes, particularly related to methamphetamine. And then unexpectedly, because again, the mental health and the psychosocial, those ancillary needs were not initially one of our primary targets, but we did see that we were able with this pilot trial to, as we introduced those components to the model, that we were able to move the needle there as well. So then after we were done with that randomized pilot, we were, like any other research project, we were going to close down. And the local family welfare, child welfare system asked us if there was any possibility that we could continue to provide these services in the community. So keep in mind at that point, it was only 31 mothers that we had served, a few from that feasibility trial too. So we can call it, under 40 mothers that we had been working with. And at that point, they had already determined that we were filling a gap here in the community for families involved in the system. So at that point, what I did is I went ahead and opened a clinic. And that clinic originally was only offering FAIR. Now we offer a number of different evidence-based programs that are developed at Oregon Social Learning Center. But originally we were focused really on getting FAIR into the community. And so what we did is then we opened it up to all parents. Although our evidence base at that point was only for mothers, we opened it up to fathers as well. And we opened it up to our entire county. So regardless of where folks were living, that we would be able to go out to them. We developed a contract with Medicaid so that we could start billing OHP. As a result, we needed to make sure, obviously, they were not receiving services elsewhere. And so with that, then that provided us with the opportunity to be able to do an effectiveness trial at this real world brick and mortar clinic. And so at this point, we included both moms and dads now. And we also, child welfare were very, very clear that they did not want for us to have a design where some folks would be randomized to control without ever having the opportunity to receive FARE. But they did agree on a dynamic waitlist design. We then extended our follow-up for this effectiveness trial to 24 months follow-up instead of 12-month follow-up. And we, wanted to look at the assessment of program costs. So our research eligibility was that we would include people with substance abuse other than THC. We are in a state where THC is legal, and alcohol. And we have some other reasons for that I'm happy to go into in discussion if folks are interested. It has to do with our contingency management system. But then child welfare involvement or referral, not having your parental rights terminated at the time of referral. That's only at the time of referral. I will say there are many folks whose parental rights are terminated right after referral. Child welfare got really good at making referral before we had the opportunity to really work with parents to address that. And then a child of any age, including in utero. And so we do work with pregnant mothers as well. So our final sample for this effectiveness trial were 88, I'm looking right at it. 99. Apparently I can't read nor have a memory. And again, a very sort of impoverished sample that we were working with. Our baseline characteristics, I just want to show this. We're not going to linger here, but just to show that at referral, we had 70% of individuals that were referred for methamphetamine, 1% for heroin, 4% for opioids, and then some with dual referral. However, at intake, so when we actually are collecting our UAs and we're actually talking to folks using the Addiction Severity Index, what we found is that at intake, we had 99% using methamphetamine, 30% heroin, and 64% opioids. And they were reporting that they had been using those substances for quite some time. We also found that just shy of a quarter of individuals were using injection drug use. And then we see that there's both lifetime and recent instances of different types of abuse that both our moms and dads were experiencing at baseline. So then thinking about our results, so we did intent to treat analyses. And here we go. We find again that we had really strong initial engagement. You'll notice that our retention rates dropped slightly. This again is an effectiveness trial as opposed to the more well-controlled trials. But this is still far and above what we find in our comparator groups here in our local community and in the literature in terms of our engagement and retention rates. We also see really marked drops in both amphetamine, methamphetamine, opioid, and IV drug use that is able to sustain out past 24 months. So our effectiveness outcomes, really what we found is that we replicated our previous randomized pilot outcomes that I realized I didn't show in great detail, but here we go. So in sum, so we show reductions in substance use of heroin, other opiates, and then also methamphetamine. We show reductions of IV drug use. We reduced that down to where there was only one of our participants who continued to be using at the end of this trial with injection. We have these reductions in cravings and other problem drug behaviors. So those are things where we have a measure where we ask, like if drugs were put before you, or if you were to enter into a situation with peers where they were using drugs, how difficult would it be for you to be able to say no? We also see reductions in our parenting, on our negative parenting, things like parental stress. We see the mental health symptoms, depression, anxiety, trauma symptoms, and then we see improvements in those ancillary needs. Also, what we found, probably not surprising to you guys, is that over time, these correlations and how the correlations were, or how these variables were correlated with one another really shifted over the 24 months. So although substance use, for instance, was really driving those corollaries early on, what we found is that then mental health symptoms started to really be what was driving the corollary relationships. And so what this led us to believe is that these really are, as we know, intertwined and intermingled with one another. And so to be able to meet the needs of parents, we really would encourage being able to do this integrated approach. So often our parents told us, we've done a lot of qualitative interviews with them, conducted a lot of sort of, again, that qualitative, like, self-report. And what we hear is that when they've gone through these silo treatments, so, going through like receiving your substance use treatment here, receiving your parenting treatment over here, without having those integrated, there really is a big gap that we are missing in that, a lot of times parenting stress is what will trigger folks to go back and use substances again. Not to say that we are blaming the children by any way, shape, or form. Please don't hear that, but rather these are parents that really are in need of support with how to handle parenting stress, how to handle the different developmental challenges that their parents experience, that their children experience, especially when we're talking about kids that have likely spent some time in foster care, or if they haven't, they have been exposed to substance using lifestyles of their parents. And so really wanting to help parents navigate that as these things do shift over time. What we did find from some of our interviews then is that we found that a lot of parents were really identifying and talking about the fact that they believe that FAIR would be helpful for them in ways not just related to their substance use. So it can help a lot of people that aren't even going through addiction, but just need help learning how to cope with different problems in their lives. I would say that it's a great support for families, and there are a lot of different things that they can help you with, whether it be your children in relationship sobriety, or giving you tools that you may not have or that you may not have realized that you have, and just supporting you with those sorts of things. So with these sorts of outcomes and reports from others, this then spawned us to think that we could have the opportunity to really act on some of the NIH HEAL initiatives that were coming out. We're now looking at preventing opioid or methamphetamine use. Working with Gracelyn Cruden, who was a postdoc with me at the time, she's now an early career scientist on my team. What we did is we conducted causal loop diagrams with different parents, with former parents who had participated in FAIR, to really understand what is it that was driving these outcomes then that we might use from a preventative standpoint. I know that there's a lot going on here, but basically, the long and short of it is parents were really identifying that there was so much that was necessary for them that had nothing to do with the substance use component, that we recognize that these are parents that really what we're doing is we are trying to help create stability with those unmet ancillary needs. And with a lot of the parenting over here, you see the parenting mental health systems with a big cluster around there of activity. And so we decided was that for our adaptation, we really weren't going to be changing the model that much. We were going to be changing the intensity of the model and what particular things we were targeting. So less emphasis on substance use unless another substance use disorder is identified. And so we absolutely are working with parents now who have been using THC more than they would like and feel like it might be interfering with their parenting. These are all folks that we absolutely would say would be qualifiers or eligible for pre-FAIR, because pre-FAIR is trying to prevent the onset of opioid or methamphetamine use, but then not these other risk factors. We also can meet with folks less frequently and can use our Zoom options. Zoom FAIR is something that was developed out of necessity from COVID, but we have found really strong and good effects using Zoom as a method for FAIR during our COVID time. So we've now introduced that as part of pre-FAIR. And then we are thinking that our length of treatment might be less, but I'm not actually sure that that's going to be the case. Part of the HEAL grant that we received then from NIH was then the first planning year, we worked with the state here in Oregon, and we worked with both child welfare and self-sufficiency programs. Self-sufficiency is like TANF, housing, things like that. And so we worked with both of these public serving systems to really help identify of the 36 Oregon counties, which were the counties that were most in need. And we identified need based off of the ratings that you see see here. So, families living in that area who are identified as being in need for child welfare or self-sufficiency. But in addition to that, where there were not services already available. So where there's high need, low service access. And so, of course, probably not surprisingly, we end up in some of our big rural counties here in Oregon. We originally proposed that we were going to be in 2 counties. We are now operating in 5 counties here in this part of the state. We do have an implementation plan that follows the stages of implementation completion. For folks, I don't know how many folks on the call here are listening in to a talk later on today that I'm giving about the SIC, about that as a method that we use for measuring and operationalizing implementation approach. But really what we do is we break down pre-implementation, implementation, and sustainment needs. And this is just an example of all of these different implementation activities can be broken down into multiple steps of things that an agency or a provider team needs to do to be able to develop a new plan so that they could implement a program like FAIR successfully. So for instance, a funding plan review would include contracting with Medicaid for reimbursement, figuring out your mileage rates, specifically for going out to these very rural regions, et cetera. We do have active implementation strategies that are the same for both FAIR and pre-FAIR. So we provide on-site training, some of the things you guys are familiar with, coaching, virtual office hours, support with them building their FAIR store, and then offering on-site remote fidelity monitoring using a tracking tool that we developed. We also have an app that is available that we developed as an administrative supplement to be able to track parent progress. So we started off, these were the 2 sites that we were looking to start at in Newport and in Albany, Oregon. But then we have another site here in Oregon, in Eugene, one in Roseburg, and then another one in Sutherland now. So one of the things that we found, though, is that I would say is that we've experienced a challenge for prevention. And that is that pre-FAIR side of the coin that we are really hoping to evaluate as part of our HEAL project. That's still an ongoing project. But we've been really challenged in getting pre-FAIR referrals. Although we have gone into more counties than we had anticipated, those counties right now, Oregon is really, really suffering a huge methamphetamine and opioid crisis. Some of you might have read about it in the news. It's been in the news repeatedly. And really what that means is that these counties that did not have any services are desperate for treatment services. So we have wait lists everywhere for our FAIR treatment, so that original FAIR treatment model, but we are really struggling in getting our pre-FAIR referrals. In talking to child welfare and self-sufficiency about that, quite honestly, it's because they are having a hard time managing because there is this high need for those families that are deeper into the system. And so that is a challenge. That is a challenge for us with prevention. But one of the ways that we might be able to address those challenges are with a model such as R3. So now I'm going to switch gears and spend the last 10 minutes of my time talking with you guys and introducing the R3 supervisor strategy. This R3 supervisor strategy came out of a request from New York City's child welfare system, and they were interested in getting help developing a model where they would be able to ensure that every single family that walked in the door of a child welfare agency would be met with evidence-based interactions. They had identified that a lot of their special needs populations were involved with evidence-based practice, but that the large majority of families that walk into a child welfare agency aren't in need of those deep end services. And so they were not receiving those types of services. And so how is it that we could then infuse evidence-based practice within the frontline casework staff of just general regular caseworkers? Well, we looked to the FAIR model and what it is that we do for FAIR group supervision to be able to develop this R3 strategy. So just in thanking my R3 team. So as I mentioned, the R3 strategy, the idea is to bring the EBP into every interaction between the workforce and families. Ideally, this means every single person that they come into contact with. So not just their caseworker, supervisor who greets them at the front desk, the security guard who's standing at the door, because what we know is that how families feel when they enter into that door really, really influences their engagement with the system and therefore their engagement with their child welfare treatment plan and ability to exit the system. So it can really shape the direction and success of a case. R3 really, this is what you see here is sort of the standard or typical hierarchy that we see in a child welfare system. Of course, there are multiple different in-between levels, but this is sort of the basic structure. When we first originally were asked to do this for New York City's child welfare system, we were originally thinking, okay, well, we're gonna do this at the caseworker level. They're looking between caseworkers and families. We very quickly, and I mean very quickly, within like 2 weeks, realized, well, that is going to be impossible to monitor for fidelity. So we went back to the drawing board and we created the R3 supervisor strategy, where we would really target supervisors. We wanted to target the interactions between supervisors and caseworkers, viewing them in their group supervision to understand if supervisors then were really reinforcing that direct work between caseworkers and families, in turn with the idea being that we would experience a trickle effect in between families and the children. The idea being that this is a self-reinforcing loop, and that if we see those outcomes there, that we then would start to be reinforced at the system level, so at the top, to create a more reinforcing system overall, improving the culture and climate of the child welfare agencies. So this aligns with a model from Greg Ahrens and colleagues that they present related to organizational processes and implementation, where really what we're looking at is, again, shifting organizational culture, leadership, and climate, but that's because it is on the foundation of modifying implementation, climate, success, and attitudes. So R3, I sort of joke sometimes because it is so simple, and yet it is really, really challenging to move the needle on the system about this. And so it is called R3 because there are three basic R's, three basic reinforcement strategies that we are using that we pull from the evidence-based parent literature and from, again, the idea of what it is that we're doing in FAIR and some of the other OSLC interventions. So reinforcement of effort, just basically acknowledging with parents what is the effort that they are putting forth and toward their treatment plans. Reinforcement of relationships and roles. This one is my most favorite, particularly when working with child welfare systems. A lot of times, and in trainings, what I say is that, caseworkers and folks that get jobs in the child welfare system do so because they care about kids and they enjoy kids. And so it's really reinforcing when you get to a house and a kid runs up to you and hugs you and says, "Oh, thank you, Lisa, for coming today. I love when you come." That, although reinforcing and rewarding, is not what we want to see. What we want to see is we want to see that child having that level of sort of attachment and commitment to their parent. And so really redirecting that and reinforcing the relationship with the parent is one of the key things that we're really striving to do. And then reinforcement of small steps. Again, not rocket science. We all know that in order for me to accomplish a goal, I might need it broken down into much smaller steps than you do. But really recognizing what level of small step does a parent or a family need to move through the child welfare system. We then have this mounted on 4 principles that you are very familiar to you guys from the parenting literature. So we use strength-focused language. We really notice normative and appropriate behavior, not just exceptional behavior. So we want parents, as I often say, in order to get into the child welfare system, your parenting needs to be subpar, but in order to exit the child welfare system, often we expect for you to be exceptional and above sort of normal parenting standards. So really bringing those expectations back down for caseworkers. looking and taking the opportunity to use humor. Not only do we have to laugh to keep from crying sometimes, but that really, really helps in interacting with parents to set a tone and helping them feel like you guys are like we're, you know, bonded together and working on this together. And then, as I say, use a scientific approach. We are always observing and looking for opportunities to reinforce our families. So R3 is really grounded in group supervision, as I mentioned, because we're targeting the supervisor caseworker interactions. And we say that teamwork is the key to success. We do observe supervision once a month. We are looking at basically shared problem solving and social learning. And so, you know, social learning means that as I observe you getting reinforced for one of your behaviors, I encode that and I think to myself, maybe I'll try that too. And it goes both ways, right? So there are things that I see you do that I don't want that reaction. There are things that you do that I do want those reactions. So group supervision really promotes those opportunities. So we have our group supervision. It is being observed. It is either video or streamed. It was either recorded or streamed. That depends on the environment we're in and whether or not they allow recordings. That is viewed by an R3 coach that provides a fidelity rating. And then the supervisors, each individual supervisor gets written feedback on their meeting, but then they are joined in a coaching group of 4 to 6 supervisors once a month with the coach, where they talk about sort of shared themes. What are things that were observed by that coach in each of those different supervisors' meetings, and what are the themes that we can pull out and really reinforce? And then we do that again. And so we did this in New York, as I mentioned, where that was requested. We conducted the pilot project there, had huge success, and especially qualitatively. Some of the agency leaders that we were working with there were mentioning that they had greatly reduced the number of, for instance, police that they needed to call to their waiting room for disruptions, that they were seeing that there are lots of improvements in family outcomes, but this was a pilot project. So then when that project ended, Tennessee, the state of Tennessee had heard about R3, and they requested that we come in and help work with them in some of their poorest performing regions. And so we had the opportunity to go to Tennessee and work in 12 poor performing regions. And again, use the R3, those R3 strategies, the training that I mentioned. And what we found is that 44% of supervisors achieved delivery of R3 consistently within the first year. So within the first 12 months, that is the fastest you can get certified in R3. So I didn't show, I thought I had a slide, but I apologize. I must have taken it out, a slide of our certification criteria. So essentially what that means is that you have been receiving coaching for at least 12 months, and that you've had the last 3 months, you have operated in the quote unquote green. So we do red, yellow, green for your fidelity ratings. And so if you've been in the green, meeting fidelity standards for 3 months in a row, and had at least 12 months of coaching and had good attendance at your supervision meetings, then you can be certified. So here again, so we see 44% could receive it within that first year. So the shortest that you can, 80% by 18 months and 93% by 24 months. And one of the things that was super exciting for us is that we had 3 supervisors who started out as caseworkers, but they were being coached by an R3 supervisor, and they moved into the green. They started out in the green rather when they were promoted to supervisors. So that lets us know it really was infused through those supervisor caseworker interactions. What we found then is, so overall in Tennessee, child welfare units trained in R3 showed an increase in organizational climate. We show caseworkers' perceptions of supervisors' leadership was associated with fidelity. We see that supervisors' perceptions of organizational climate predicted their own fidelity over time. But interestingly, what we saw is that supervisors provide a buffer to their caseworkers. So while we were working in Tennessee, there was leadership change. And when there was leadership change, the enthusiasm for R3 rapidly decreased. New leadership was not too jazzed with the way that we were providing supervision or encouraging folks to provide that sort of positive focused supervision. So as that change happened, what we found is that although the supervisors experienced a decrease in sort of their feelings of positive climate, the caseworkers that were being supervised by certified supervisors, they did not experience that. So again, the supervisors can sort of serve as a buffer, which is incredible when we think about maintaining improved organizational climate for a child welfare system. System level outcomes, we saw exactly what we'd like. So we saw that families with close cases with R3 were less likely to be re-reported. We saw that caseworkers who received R3 were more likely to achieve their permanency goals, achieve case closure more quickly, and they achieved the strongest family outcomes based off of the FAST, which is the sort of the family rating that they use there in Tennessee. And then we saw that supervisors who achieved certification but then are in the system that did not support R3, we went and we evaluated them again a year later. And what we saw is that a lot of the supervisors were slowly starting to revert back to sort of baseline again. So when we had exited the system and they were no longer receiving those R3 supports, they went back to homeostasis after about a year. It took a little bit over a year. And then now, just very quickly, because I'm recognizing we're short on time, we brought R3 then here to Oregon, where again, we are doing those, the FAIR pilot or the FAIR project that I was talking about. And we went into two of the largest regions that we are in with FAIR. And these regions were identified because these are regions where the opioid epidemic is just really exploding. So we have now here trained 154 staff and 15 supervisors in one district in Douglas, and in Lane, we've trained 265 staff and 38 supervisors. We are just now finishing this project, but so far we've been here for we started with them right at the beginning of COVID, and things have been going very well. And so I won't go through all the different implementation strategies, but this is what we've done across the way. What we have in purple or what I'm showing that we have been doing differently here in Oregon. So because of COVID, we're doing Zoom. We're not able to record. We're having to stream. We have done leadership meetings quarterly, but they're now in Zoom. And we are doing, we train the entire workforce here. So unlike Tennessee and New York, they asked us here to train every single person. So that means the janitorial staff, the reception staff, everybody. We also started to provide a weekly newsletter of R3 tips to help them manage during COVID-19 stress. And so here very quickly, I can just show you so you can see a lot of folks started off in the yellow already, but then that got transitioned. You just see basically a reverse mirror image of one another as it transitions into the green. And we see that the few percentage of staff that were starting off what we would say in the red really decreased pretty quickly by about 5-6 months, and then maintain that low status over time. And so here we see we move the needle much more strongly here in Oregon, even during these times than we did in those other settings. And so we really drove it home in terms of the implementation climate, citizenship, readiness, leadership, et cetera. So just some final reactions from supervisors is that we hear here in Oregon, I didn't want to do R3 at first, and now it's my favorite meeting of the month, just breaking us down into groups and being with people that we wouldn't have been with, having those interactions and difficult conversations with. It's been eye-opening to me. It's really brought us, the management team, a lot closer together. That final one in my unit, folks are trying to be more positive. They're trying to be creative in how to work with families, even with COVID. And yet in the past few months, we've had every single worker had at least one child go back to a family. So I will say, though, with R3 that we've had a little bit of a mixed bag, because as I mentioned, it didn't really stick in New York, despite our great outcomes when they had a leadership change there. Didn't really stick in Tennessee, even though we had really great outcomes when they had a leadership change there. And so here in Oregon, what we found is that although it has really done well in the counties that we're in, and they are going to maintain it in those counties, they are not going to scale it up in the other counties. because of some decisions that have been made, again, with leadership change. We just experienced a leadership change here. So basically, this hypothesis of it going up and reinforcing the system, that part is not holding true. So in conclusion, R3 can demonstrate success across these different systems and contexts. So again, just sort of summarizing what I've already shared with you, and system level sustainment differs from individual level sustainment. So really, although those system level interventions require the support of those not directly impacted, such as leadership, those are the very people who can impact whether or not a model such as R3 sustains. So that's it. Thank you. I'm going to stop share and hopefully we can have a brief discussion.